Hello, everyone, and thank you for joining us today for the SBIRT Challenge, an exploration of implementation barriers, facilitators, and sustainability in social work and interprofessional health training programs. I'm Tracy McPherson, and I'm going to be your webinar moderator today. I'm a senior research scientist in the Public Health Department at NORC at the University of Chicago. There, I lead the SBIRT Training, Technical Assistance, Implementation, and Evaluation team. And I invite you to contact me if you have any questions about today's webinar, any webinar in our series, or if you have general questions about SBIRT and the work that we're doing at NORC. Today's webinar is produced in partnership with the Brief Intervention Group, or BIG Initiative, at NORC, and the National Screening, Brief Intervention, and Referral to Treatment, or the National SBIRT ATTC, funded by SAMHSA. And today's webinar is also produced in partnership with our partner, the Council on Social Work Education, or CSWE. The materials for today's webinar, including the PowerPoint slides and any other resources that might be mentioned during the webinar, will all be posted on our hospitalsbirt.webs.com website. There's a special page dedicated specifically to this webinar. In addition to the materials, that's where you'll find the on-demand recording once available, and as well the links to be able to request your certificate of completion. At the conclusion of our webinar today, we'll have the opportunity to talk to you more about some of the questions that you probably will be developing over the course of today's webinar. And so I would encourage you to get those questions in early. So don't wait till the end. If something, pops up in the beginning of the webinar, go ahead and get it into the queue using your questions pane. Typically, the questions pane in GoToWebinar is up in your upper right-hand corner. You'll see a little gray bar area. Typically, it says questions. You can type in anything. It puts them in the queue, and at the end, during our Q&A session, I will moderate a Q&A session with our presenters. And behind the scenes is our technical facilitator, Misty Story. She'll be able to facilitate, any kind of technical issues, questions about where to find the PowerPoints and things of that nature. She'll be behind the scenes, be able to respond to you. And so I just want to take the time to say thank you to Misty Story for all of her support on today's webinar. And our first speaker, who is really our co-host and our partner in today's webinar, is Andrea Diaco. And Andrea is the Associate Director of Education, Initiatives, and Research at the Council on Social Work Education, or CSWE. And so I'd like you to join me in welcoming Andrea. And Andrea, I'm going to turn it over to you for some opening remarks.
Great. Thank you, Tracy. I'm very excited to be participating in the presentation today. Screening, brief intervention, and referral to treatment, also known as SBIRT, is a comprehensive, integrated public health approach to the delivery of early intervention, treatment, and ongoing recovery supports for persons with risky and/or dependent alcohol use. Previously, there has not been much support for SBIRT training in social work graduate and undergraduate programs, despite the fact that alcohol and substance abuse prevention programs have a large body of supporting evidence. SBIRT education and training is often optional or specialized education, as opposed to being required coursework. The Council on Social Work Education was awarded a subcontract from the Independent Research Organization, NORC, at the University of Chicago to support the integration of substance abuse screening, brief intervention, and referral to treatment into general undergraduate and graduate social work curricula rather than in advanced practice or specialty classes only. The expansion of insurance coverage for preventative care and substance use services by the Affordable Care Act and parity legislation makes approaches like SBIRT increasingly relevant to social work educators and practitioners. In October 2014, NORC partnered with the Council on Social Work Education, the Center for Clinical Social Work, and the American Association of Colleges of Nurses to support the integration of adolescent SBIRT into required coursework for their students. This is a 3-year project aimed at developing and evaluating curricula for undergrad and graduate students. All schools are invited to participate in the Learning Collaborative with NORC to share their experiences, learn from other educators about integrating substance abuse education into existing curricula, and obtain additional resources and materials. Please feel free to contact me for any additional information. I will now turn the presentation back over to Tracy.
Well, thank you, Andrea, and we really appreciate your support and partnership on this project together. And I would invite everyone, if you are interested in learning more about the project or participating in the Learning Collaborative, you can visit the project's website at sbirt.webs.com. And there you'll see a whole host of information, not just about the project, but you'll also see we've made available to you a curriculum, a full curriculum with PowerPoints, learner's guide, all the materials you could ever want and more on our curriculum page of that website. And if you'd like a copy, all those materials are made electronically available to you at no cost, and you're welcome to request a copy. So just go to the sbirt.webs.com website, click on the curriculum tab. In addition, I'd like to mention that as a part of the Learning Collaborative, one of the key pieces of the Learning Collaborative is our opportunity to share and learn from each other. And so today's webinar really gives us an opportunity to do that. We have 2 presenters today. We have Lydia Ogden and we have Cynthia Montgomery. And both of them have a lot of experience in the implementation of SBIRT in their programs. And this is that real learn and share opportunity to hear about their experiences on the ground, what they've been doing in their program, where they're going, and to really help those of you on this webinar today learn from them and share. And it's hopefully be an opportunity to engage and discuss. So let me first invite you to welcome with me Lydia Ogden. Dr. Ogden is a licensed clinical social worker and associate teaching professor in the Human Services Department at Northeastern University. From 2012 to 2016, she was a co-principal investigator on a project funded by the U.S. Department of Health and Human Services, SAMHSA, Substance Abuse Mental Health Services Administration, as part of the Screening, Brief Intervention, and Referral to Treatment, or fondly known SBIRT, Medical Professional Training Program. She and her co-authors, Mohan Venjamuri and Jessica Khan, recently published findings from the project in an article called Translating SBIRT into Social Work Practice, an empirically based model, in the Journal of Social Service Research. The article presents a detailed description of the barriers and facilitators around implementing SBIRT training in BA and MS level social work programs. Her other SBIRT-related publications to date appear in the Journal of Baccalaureate Social Work Education and the Journal of Social Work Education. So thank you, Dr. Ogden, for joining us today. And I'm also going to introduce Dr. Cynthia Montgomery. Dr. Montgomery is a licensed independent provider at the Alaska Psychiatric Institute. She is also an assistant professor at the University of Alaska Anchorage, where she teaches in the graduate program and coordinates the Psychiatric Mental Health Nurse Practitioner Program. Dr. Montgomery has been instrumental in implementing the SBIRT training in the undergraduate nursing program and assisted in the implementation of interdisciplinary SBIRT simulation at UAA. So welcome, Dr. Montgomery. So I'm going to welcome both of you. And to start us off today is Dr. Ogden. So I'm going to turn it over to you.
Hi, thank you for the introduction. I'm so happy that everybody is here and attending. So our goal today is to provide you with an in-depth examination of barriers and facilitators related to SBIRT implementation. And we're going to give you sort of case studies of two different programs that we've looked at. Next slide. Attendees, our objectives for you are that attendees will be able to critically compare differing influences on SBIRT implementation under differing conditions. Attendees will learn key project elements and implementation methods that facilitate or hinder the implementation of SBIRT education and its subsequent utilization in the field, and that we will together explore and gain an initial understanding of options for SBIRT program sustainability. This last piece of sustainability is something that I think a lot of programs are just beginning to explore. Next slide, please. So I'm going to start off by talking about the program that I was involved with. It was a SAMHSA project that I was part of called Enhancing SBIRT Utilization Among Underserved Populations in the Bronx and Surrounding Areas, a Lehman College training initiative for social work students and medical residents. And I'll just add here that today we're going to be focusing on the social work aspect. I recognize that not all attendees are necessarily social workers, so I've tried to keep things clear for non-social work people, but if you have any questions, please feel free to ask. Our project, as I mentioned, was funded by the U.S. Department of Health and Human Services, the Substance Abuse and Mental Health Services Administration, which we call SAMHSA, is part of their SBIRT medical professional training program, and it lasted 3 years. And as noted in the title, in my program, the social work students we trained were at a public college in the Bronx. They worked at field work placement throughout New York City and the surrounding area, but the majority are placed in the Bronx, which, as most of you probably know, is an economically disadvantaged area in a very large city. So as far as the purpose of our particular project, it stems from the fact that in addition to the logic that's already been outlined about the need for increased social work training and generalist practice, it also stemmed from the fact that the communities surrounding the school have the highest rate of hospitalizations for substance usage in the state. So our goal, in line with the CSWE goals, was to infuse SBIRT into the core curriculum in both bachelor and master level social work programs at the school so that all students would be trained in the protocol by graduation. As a high percentage of graduating social work students from that school eventually become involved in the school surrounding communities, it was hoped that also this project would have an impact in their preparedness to assess, provide brief interventions, and make appropriate referrals with substance use clients in that area by improving knowledge of substance use in general, SBIRT in particular, and also by addressing through education attitudes towards substance users in general. Next slide, please. Great. So you'll see here I created a pie for you all. So I'm going to start by telling you a little bit about what our project looked like. I'll tell you all the pieces of our SBIRT project pie, and then I'll move on to telling you about our findings around barriers and facilitators. I'm guessing that for this audience, I don't need to go into a description of what SBIRT is or the evidence that supports it, but if you have questions, please go ahead and ask, and I can fill you in a little bit there. Also, although, again, as I mentioned earlier, even though we did train medical residents, I'm going to focus on social work training. So our project model. Our model had several defining features. are all pieces of our pie. We used a train the trainer model so that the social work faculty on the grant who were trained in SBIRT then trained all of the other social work faculty, who then went on to train the students. The social work faculty on the grant also trained some fieldwork instructors, and I'll tell you a little bit. That was voluntary, whether fieldwork instructors wanted to do that or not. The trainings included, so the trainings for the faculty included guest speakers, role plays, and workshopping the SBIRT curricular material. So in collaboration with all of the faculty who were going to be teaching in classes that were part of the core curriculum where SBIRT was going to be integrated, we created a manual for students that followed with a PowerPoint lecture slide that the faculty used. And we developed a book of role play scenarios and exercises, and we created a visual aid, the kind that you often see that people use with SBIRT. And we did this as a group with the faculty who were training to get their input and their expertise. Of course, we're a school of social work and had a huge amount of expertise both in teaching and related to substance use and clinical social work, and to make it more relevant to social work, as well as we included them also to enhance the buy-in. So, you know, in the interest of transparency, I've already said we had this grant, so some of the faculty buy-in that we had may have come because of the grant money. They were provided with some summer salary money, but we also included them in a huge amount of the planning. So both, like I said, to improve the material, but also so that they were more invested in the material than they might have otherwise been. And this, I think, became important later, as you will see. All right, so the second part of the pie was that we integrated SBIRT into the core curriculum of the social work program for all 3 years of the grant. And in fact, we did extend it afterwards, at least it's extended now. All graduating master's and bachelor's level social work students were trained in SBIRT as part of their core coursework. For master's students, they were taught the material in a second-year fieldwork placement seminar, and for bachelor students, they were taught the material in their only fieldwork seminar senior year. So the first year, because of the timing of the grant, we taught the material early in the spring semester, and again, that's something that becomes important a little bit later. So to teach the material, like I said, we used the PowerPoints, we used the manual that was a companion to the PowerPoints, and then faculty had academic freedom to use role plays or not, use videos or not, and we provided a selection of both. I'll throw in another word about faculty and academic freedom here. So before we even applied for the grant, we checked in with faculty to see if they would be willing to integrate it into their courses if we got the grant. So, and they agreed to that. So they had academic freedom to how they wanted to integrate it. But because they had helped us to develop these PowerPoints and this manual, most of them were, I think all of them were using that. Again, I'll come back to that in a little bit, sort of the idea of model fidelity. All right, the next piece of the pie were pre and post-test and 30-day follow-up measures that looked at student satisfaction with the training, knowledge about SBIRT, as well as attitudes around working with substance-using clients, particularly interest and self-efficacy. So we created, the student satisfaction survey came from SAMHSA. We created a knowledge test. And then the attitudes test, we used a modified version of the drug and drug problems perceptions questionnaire that I have the reference for it. I'll show it to you later, but that's Watson, McLaren, Shaw, Nolan 2003 article. And we also looked at their perceptions of the usefulness and effectiveness of SBIRT. And all of these measures were given in the classroom. All of these evaluation measures were in the classroom. Slice number 4, to further enhance the likelihood that students would use SBIRT in trainings, we did some community outreach. We sent a letter to all the fieldwork placements explaining what we were doing. We asked fieldwork advisors, so those are the faculty trained in SBIRT, the core faculty who's been part of this collaborative piece all along, to talk with the social work to talk with their students' fieldwork instructors about SBIRT to see what they thought about the material and if they thought it was appropriate for the students to use in placement. And then we offered free trainings to fieldwork instructors. As a side note, in the second and third year, there were continuing education credits offering an introductory and advanced training and then a special topics training. So for the first year of data that I'm going to focus on today, we had about 180 fieldwork instructors who we trained. There were 180 fieldwork instructors total, and we trained 89 of them, which is about 49% of them in this intro to SBIRT where they didn't get the free CEUs. And I'll say the reason for that is because New York State did not require CEUs, and therefore we could not get CEUs until the second year, and that changed. All right, slice number 5. At the end of each year, we conducted focus groups with randomly selected fieldwork instructor students and then all of the social work faculty involved directly with the project. And then finally, 6 months after students graduating, we sent out a postcard survey and also sent the same, sent an email with the same questions that were on the postcard survey, and in fact sometimes followed up with phone calls asking whether students who'd been trained and who had graduated had used SBIRT in the field since graduating. One thing I actually didn't put in the pie was that we also tracked in the classroom setting who had used SBIRT and what parts they had used. So if they had used just the screening, if they'd used the brief intervention, if they'd used referral to treatment. So that was another, that's a secret piece of the pie. Okay, so slide number 2. I'm sorry, next slide, please. Thank you. Okay, so I'm going to give you sort of a quick overview of some of the quantitative findings now, which after year 1, which were pretty good. We were pretty happy with what this went. With how this went. Before I go into these, I'll give you just a quick little rundown of who our students were. They're a little bit different from typical undergrads and for typical social workers. I'm saying our students. You may have noticed I'm at Northeastern now, but this was I was part of Lehman when we did this. Okay, so our students. So the mean age of the MSW participants was 32.7 years old, with 29% were male, 69 female, and 1 transgender. I'm sorry, 69% female and 1% transgender. 42% of the MSW participants identified as Hispanic, 36% identified as Black, 18% as white, 1% as Asian, 3% another race, and 27% reporting that they could speak Spanish. For the Bachelor Social Work participants, the mean age was 29, with 14% reporting that they were male, 86% female, 53% of the BA participants identified as Hispanic, 33% as Black, 6% white, 4% Asian, 4% another race, and 45% reported they could speak Spanish. And when we're asking them if they can speak Spanish, it's if they can speak Spanish to use it with our clients. 30% of the MSW participants and 40% of the bachelor's participants were born outside of the United States. So 218 students total were trained, with 82 MSW and 136 bachelor social work. 181, or 83% of the students, completed all 3 of the pre, post, and 30-day follow-up measures. So I can go into a little, if you have questions, I can tell you a little bit more about the numbers, but just to give you this review, overall we had about 60%, 131 out of 218 of our students used SBIRT in the field. And overall, they found that training was useful. The vast majority, 95%, found the training useful and effective, and their knowledge about substance use and working with substance users improved significantly according to our evaluation measure of it. And they became more confident in working with substance users and using SBIRT in the field. And that was according to the CDPPQ. So we really considered that a successful first year. I'm going to add here that when we did the this is new, hot off the presses information. We've written an article about this. It's not yet been published. I'll add that when we did the 6-month post-graduation follow-up surveys, we got responses from 98% of the master's social work students and 91% of the bachelor social work students that are graduates. And we found that of those participants who were working in social work, 44% of MSW students were using SBIRT and 42% of our bachelor's students, or I should say our graduates were. Again, this is a pretty good statistic. However, all of these statistics could be improved. Okay, next slide. Thank you. So here we have this beautiful model, and I'm going to tell you, I'm going to sort of break it down piece by piece for you now. The model actually comes from our focus group analysis. So we conducted focus groups immediately after the first academic year in which we had held the SBIRT trainings. At that point, we didn't know some of the stuff I've told you about. Like, we didn't know about the use of SBIRT after graduation, but we did know that students had used it in some of the fieldwork placements, had gained knowledge and confidence, and more so if they had used SBIRT in their fieldwork placements. Our focus of the focus group, there's a little tongue twister for you. Our focus of the focus group was students, faculty, and field instructors. So there were these 3 field instructors, was to understand what they perceived as barriers and facilitators of the use of SBIRT in the field so that we could address those things in years 2 and 3 of the project. So again, these are the focus groups after year 1. Overall, there were 8 participants in the student focus group, 10 in the faculty focus group, which was all of the participants except for the project director, myself, and somebody else who was involved in the training. We thought our presence there might excessively bias the responses. And then the field instructors, there were 6 participants. So overall, there were 24 participants in our focus groups. And we transcribed this focus group verbatim and analyzed with dimensional analysis. And that's how we came up with this model that you're looking at. So the first thing I want to point out to you is the issue of time and timing. You can see our little, at the very bottom center, the words time and timing with arrows pointing up. I had mentioned this earlier, that we had given the training to the students, the classroom training to the students in the spring semester for the first year of the project, and all focus group members agreed that the timing was late. They thought that the material should be taught earlier in the year so that when students were first meeting and assessing clients, they could right off the bat be doing the SBIRT screening. So that was an easy fix for years 2 and 3 of our project, and that's a change that we made. The next issue was the amount of time, so different from timing, the amount of time that SBIRT took up across classrooms, in the work of the students in their fieldwork placements, and in their supervision and fieldwork placements. Faculty did not develop consensus on this issue. Some felt that SBIRT in the core curriculum took too much time away from their regularly scheduled programming, and others felt there was not enough time allotted to them to teach it as best they could. They talked about feeling frustrated by this lack of time, and that they, in quotes, could have done a better job if one said, I could have done a better job if I'd had a longer period of time. So there was some frustration there. Students agreed, or at least with a sentiment that there wasn't enough time. They felt that they needed more classroom time to develop the depth and detail and confidence needed to really practice it. One student was talking about, I didn't have enough time to absorb all the information so that I felt confident going into my field placement. So not having enough time left the student not feeling quite confident. Fieldwork instructors didn't comment that if it took too much time for students to supervise students around it, or that it took away from their work with other clients. So the fieldwork instructors were neutral on this. Moving along, we'll also notice on the top right, there were agency factors that were important. Because fieldwork instructors acted as gatekeepers and liaisons between the college and practice in their agencies, any lack of mastery around SBIRT on their parts could shape the agency context faced by students. So many fieldwork instructors had concern and confusion, and there were conflicting agency policies. And this was both reported by faculty's experience as well as the fieldwork instructors themselves. So for example, adults with developmental delays and adolescents, fieldwork instructors working with those populations had some concerns and confusions about whether parents or guardians needed to be told about client substance use as part of mandated reporting. So some fieldwork instructors proactively addressed this barrier by developing documents and protocols and ways to deal with substance use disclosure. Other fieldwork instructors actively tried to integrate SBIRT into the agency culture and referred, actually, in more than one case, referred the college to the agency HR to see if the whole staff could be trained. So agency culture that promoted continuing education certainly helped to facilitate SBIRT. And I'll just remind you again that in the first year of the program, CEUs were not required in New York State where we were running it. So after, in the second and third year, maybe there was more agencies that were more supportive of continuing education because the licensing was, after that, was going to be required. I mean, the continuing education was going to be required for licensing. But in the first year, there were field instructors who couldn't attend the trainings, and they felt that because they haven't been able to attend trainings, they couldn't provide good enough feedback to students. Others who were swamped, such as with a heavy caseload, multiple interns, felt that it was just impossible, even though they would have been allowed to, it was just impossible to attend the training. So I mentioned in the first year, 89 or about 49% of the school's fieldwork instructors received the SBIRT training. To improve field worker instructor buy-in and to decrease the barrier of the, or the potential barrier of the agency or instructor, we did, as soon as CEUs were introduced to New York State, we added them in to our trainings for years 2 and 3, and we added that advanced SBIRT training that I mentioned before, as well as SBIRT for special populations. We did one SBIRT for older adults, and all of these had CEUs with them. For faculty, in the first year of the program, we sent out, I mentioned that they sent out a letter to fieldwork instructors telling them about the SBIRT initiative, and we'd invited them all to be trained in SBIRT. However, most faculty left in the first year had left the students to negotiate whether they would use SBIRT, that they would negotiate that with their field instructors on their own. And we discovered very quickly that it went better when faculty field advisors did this as part of the annual site visit. So the program adopted that model across the board after the first year. One of the barriers had been that students were not being allowed to use SBIRT because their agencies perceived it was not appropriate with populations being served. Age was often perceived or misperceived as a barrier. I say misperceived because there were students who were able to use SBIRT with clients of all agencies, of all ages at other agencies. So there were like some places that were saying, like, we have older adults, we can't use SBIRT, and then we had students using SBIRT with older adults in other agencies. So agency misperceptions about the applicability of SBIRT was a barrier that we corrected by faculty field advisor site visits that happened in the fall and had specific, we asked them to specifically address this. We really felt that asking students to do it was really requiring a higher level of knowledge of SBIRT and advocacy skills than we could reasonably expect. So for years 2 and 3, the faculty really, I think the majority of them did end up covering SBIRT in their site visits. For students, fieldwork instructors' mastery of SBIRT shapes the agency context for them, and generally that came from whether the fieldwork instructor had attended our training or not. One student, although there was still some confusion, we had one student in the focus group said she had a fieldwork instructor who's really excited about SBIRT, a lot of buy-in, but since they were both learning at the same time, figuring out how they could make it work in their agency, they were constantly, the student was sort of acting as a go-between between the faculty advisor and the fieldwork instructor as they were figuring it out. So one thing that we didn't have the capacity for, but that might have helped address this barrier, would be just a faculty consultant who could directly communicate with fieldwork instructors. Students were cognizant of the relative importance of SBIRT in their agencies, and this was, I thought this was actually pretty insightful of our students. So one example of this was that one student was placed in, who was in our focus group, was placed in a welfare to work program where the focus was on meeting quotas for job placement. So SBIRT was really relatively unimportant there and actually could be problematic. The student had explained, this is her quote, "I don't think that my agency was able to kind of see the importance of SBIRT the way my field instructor saw it or that I saw it, because if an individual disclosed to you that they have a substance abuse issue, they were immediately referred out for treatment. So, and then if they were referred out to treatment, their census dropped, which could be a problem. And their job quota placement stuff, they might not meet their quotas. So the need to refer out was actually a problem for several of the agency settings, including some with adolescents, because referring out meant a decreased client census, and then that could affect agency quality assurance measures in a variety of ways. Professional identity was a factor that we identified as being relevant to our focus group participants. So you'll see that in the circle, the bubble surrounding the field instructors, the faculty, and the students. So this was a factor that we identified as being relevant to all of the focus group participants. For this project, we conceptualized or defined professional identity as a perceived fit between new material and professional values, responsibilities, and practices within each participant's set of roles. All three groups, and I think this was important, had dual roles in the project. So the faculty were both academics and social workers. Students were both classroom students and social work interns, and fieldwork instructors were both professional practitioners and then instructors and supervisors for the student interns. So within the overarching category of professional identity, we found that there were these subcategories that each group considered or was affected by as they were thinking about how and if to facilitate SBIRT into their practice, whether it was their practice of teaching or their professional social work practice. So there was pedagogy, which was about how faculty and fieldwork instructors taught new material, and then also student responses to different teaching approaches. And then there was mastery, the level of proficiency that members of each group had related to the SBIRT material. And combined mastery and pedagogy influenced, we saw that this combination influenced if and how the faculty and fieldwork instructors integrated SBIRT into teaching and practice. Then there was also this idea of authenticity, and you'll remember that there is a lot of academic freedom, and this is where I mentioned that earlier, and this is where it comes into play. Once someone felt that they had mastery of SBIRT material, she or he made adjustments to make it feel more authentically their own. But this also meant that there were issues of model fidelity across all three groups. So not all of the teachers were teaching SBIRT in the same way. And not all of the supervisors were supervising it in the same way. And not all of the students were practicing it in all the same ways. So things were misunderstood and or misapplied. And we could hear that, that evidence of that came up in the conversations people were having in the focus groups. Another thing that was important was confidence. All three groups benefited from confidence that came from mastery and authenticity when they practiced. Many felt prepared, confident, like they were doing well. However, the perception of the value and usefulness of it was clouded by the lack of confidence in others' comments. We tried to boost the sense of mastery in SBIRT as part of professional identity through the ongoing trainings that we gave to both faculty and to the fieldwork instructors throughout all 3 years of the project. Then we also found that beyond issues related to professional identity, there were in fact interpersonal characteristics, things that seem to be maybe even personality factors that were informing responses to the SBIRT material, particularly the approach to an assimilation of new knowledge. So we found, and these again, you can see them in the smallest circle in the little bubbles that represent field instructors, faculty, and students, and the characteristics are outlined in the box on the bottom left of your slide, the slide that's in front of you right now. So receptivity was one characteristic, and for our study we defined it as how an individual thought about or processed change as a result of encountering new material. Comfort referred to feelings about new material and change, and flexibility, again, for the purpose of this study, we defined as the actions individuals took to approach new material. Members of all three groups were open to some change in their existing professional identities. The presence of receptivity, comfort, and flexibility facilitated the assimilation of SBIRT into practice, and conversely, the lack of these presented a barrier. So, for example, one receptive and comfortable faculty member stated, "I love the idea of learning about SBIRT. I love the idea of being able to utilize the terminology and the concepts throughout the semester. I just like doing something different, so I enjoyed that." In contrast, other faculty expressed discomfort with changing their usual approaches, saying things like, "All of a sudden, you had to do this completely different thing, and there was content that we had for this semester, so I wasn't really sure how to manage all that." So discomfort, in turn, diminished the receptivity when they were thinking about this new material. Similarly, some fieldwork instructors found the introduction of SBIRT exciting, while others simply cut it off, not allowing students to use it without discussing it with a student or faculty advisor. Just, no, we're not going to do that here. Students appeared to be the most receptive, comfortable, and flexible of all three groups, which makes sense because they had the fewest practice as usual tendencies to inform their responses to SBIRT. And then there was, you'll note that there's a little thing that says existing stereotypes about substance users. So all three groups had some existing ideas about substance users or substance use treatment and what that looks like or should look like. So the presence of stereotypes could seem to arise as a significant barrier, while the absence seemed to be facilitative of. We really couldn't address any of the personal characteristics or the interpersonal factors in our model, but knowledge of them could be used to gather a sense of climate for other projects prior to determining whether or not to pursue such a project. So I'm going to talk a little bit about the relationship between these factors that I've identified. So in terms of relationships, we saw that faculty strengthened their commitment to the project as they saw their students and their students' clients benefit, which they heard about through process recordings and in-class conversations. So as one faculty member described, students had actually even gotten to the point of making a referral. So when that began to happen, I felt that it had been worth it. We had clients here in the community that were ultimately benefiting from this experience, and that's what it's all about. Students appreciated professors integrating SBIRT material into coursework in creative ways. So instead of just teaching it as a finite part of the course, one student appreciated that, and this is a quote, "Throughout the course it was brought up again, so how is it going? Do you have any questions?" It was discussed and then brought back up a few times, end of quote. Conversely, some students felt their learning needs around SBIRT were not met, and that was particularly if there was a lack of classroom role-playing and integration of SBIRT with other course material, if that was lacking. One student had said that she wished her professor had a more wholehearted approach to the material. Between students and clients, we saw that as students began to see how their clients valued and benefited from the intervention, they could see its value and became more comfortable using it. And again, the converse was also true. Students who were hesitant or lacked confidence or mastery garnered less positive responses from clients, which then reinforced their lack of confidence and lack of mastery. So I should just throw in, our only assessment of that throughout the project was by looking at student process recordings. We didn't have, it was sort of beyond the scope of what we had proposed and what we were capable of doing to assess client outcomes. So we don't, that's why the client bubbles are empty, because we really don't know what they think or ultimately what they felt. It's really the students' impressions and the social and the fieldwork instructors' impressions. In terms of student fieldwork instructor relationships, concerns for professional relationships, responding to clients' experiences and feelings, ethical concerns related to client confidentiality, and concerns for overall well-being of clients affected fieldwork instructors. So, and moreover, fieldwork instructors' approaches to SBIRT influenced that of their students. Fieldwork instructors who embraced the new practice influenced students to do the same, while those who had a negative view of SBIRT likewise influenced their students to have the same view. So fieldwork instructors' responses to SBIRT were also influenced by client responses to students' use of SBIRT, as reported by the students in supervision and through process recordings. Students who were able to garner positive responses from their clients yielded more positive responses from their fieldwork instructors around the implementation of SBIRT into practice. The focus group didn't pick up on, we didn't ask questions that allowed us to pick up on faculty field instructor relationships, but since we know there were interactions, we included in this model that relationship, and we included also school factors, which we hadn't asked and investigated enough. And we used the next 2 years of focus groups to evaluate the areas we missed, and there were a few. So to summarize, this model, grounded in our focus group data, and illustrates the processes of translating SBIRT into these usual care social service settings in this effort that was really a joint effort by faculty, students, and field instructors. It shows how agency-level factors, professional identity, and interpersonal characteristics influence how the three groups, individually and in interaction with one another, were connected to barriers and facilitators to the use of SBIRT in the field. The data for years 2 and 3 are not completely out, and we haven't finished analyzing the other focus groups, but it does look like by addressing some of the barriers, such as encouraging faculty to speak with fieldwork instructors in their individual meetings with them about SBIRT in the fall, by placing the timing of the intervention training earlier in the academic year, by adding CEUs and advanced courses to SBIRT offerings, with the ongoing trainings that increase the confidence and mastery of the faculty and the fieldwork instructors. We think those things help to make some improvements. So the data that I have so far is as follows. And so you'll remember in the first year, we had 51%, 42 out of 82 of our MSW students, and 46%, which was 63 out of 136 bachelor students. And we had for year 3, I don't know if these are statistically significant, but we moved in the final year, the 46 out of 73 master students was 63% of our students. So that was a 12% increase in our master students' usage of SBIRT in the field. And then we had for the bachelor students less of an increase. We had 46% the first year, and then by year 3 it was only 49%. So like I said, I don't know if these are statistically significant changes, but I would guess that at the very least, I think the number of MSW students would be a statistically significant change. In regard to the 6-month post-graduation follow-up, you'll remember I mentioned this for the 2013-2014 trainees, 44% of the MSW grads who were employed as social workers were using SBIRT, and 42% of the bachelor students who were employed as social workers were using SBIRT. For the second, we don't have for the third year yet, but we can see 48% of the MSW students, so there's a 4% increase in MSW students using SBIRT after graduation. And for the bachelor students, it looks like there were 54% of the students who are employed, or the graduates who are employed in the field, were using SBIRT in the field. So that would be for the BA students, that's a 12% increase. Again, I don't know if that's statistically significant, but at least initially it looks like there is some increase. Adding the CEUs did bring in the fieldwork instructors and may have added to their buy-in, at least that was our hope. So for 2013 and 2014 combined, we trained, this is prior to the CEUs, we trained 116 fieldwork instructors with this 2-hour introductory SBIRT training. For 2015 and 2016 combined, when we did have the CEUs, we trained 168 fieldwork instructors. And then, so for the total for the project was 284 people. We also trained 108 agency fieldwork instructors with a 3-hour advanced SBIRT training, and then 14 fieldwork instructors received the older adult CEU training. So that's where we've landed so far with our examination of the barriers and facilitators of our SBIRT initiative. Of course, we're still working on validating our models with the 2nd and 3rd year follow-up, and to try to get a stronger association between the improvement that we think that we've seen in the use of SBIRT and the ways that we address the barriers and facilitators. But there were certainly some things that we missed as we were analyzing our barriers and facilitators. There's some things that we're still evaluating, and there's some things that were probably unique to our program. We were, after all, in the Bronx. No place like it in the world. So with that in mind, I want to pass you over to Cynthia Montgomery, who's now going to talk about the barriers and facilitators as it related to the SBIRT initiative that she was part of.
Thank you, Lydia. I appreciate that. Thank you very much. And I'm very glad to be here and share the experiences that we had here in Alaska. Our initial approach to implementing SBIRT at the University of Alaska here in Anchorage was to start out with an interdisciplinary simulation. So our study was an interdisciplinary research study on substance use, /abuse, and expert implementation in Alaska. Next slide, please. So reflecting on the interpersonal characteristics that Lydia shared with us, we noticed some here with our folks as well. So I want to go into those a little bit, and then I'll talk more specifically about the interprofessional simulation that we conducted. One of the things that made the simulation exciting for faculty and students on our campus was that it was indeed something new. We had some new faculty that came on board here in the School of Nursing who were very excited about simulation activities. We had a brand new School of Nursing building with a beautiful state-of-the-art simulation lab in there, and we were all anxious to use it. So that was exciting to have something meaningful to do in our simulation lab that involved all of the disciplines in our College of Health. So we were new at interdisciplinary work as well. We had a big initiative here on campus for that. So a lot of excitement surrounding our interdisciplinary simulation for SBIRT training. We had incorporated into this training the School of Social Work. We had the School of Nursing, psychology, and we have a justice program here too. So our justice folks were included in this as well. We were excited to work with one another because I don't know what it's like for a lot of you that are in education, but we tend here to kind of be in a silo. So it was a nice opportunity for everyone to get together and share their knowledge. And I forgot to add, we also had med students here too, physician students. One of the things that was very helpful in our implementation with this simulation project was the flexibility that we allowed. So students could come to the entire program for SBIRT training, which meant that they could come and just get some background information on it that faculty presented. They could come and get educated themselves and train and practice how to perform the screenings. They could practice just the motivational interviewing piece, and they could practice, doing a referral. So they had some different options there for their training. We held practice sessions for them where they could, come in and practice some or all of that. We set up the simulation and invited everyone to the simulation, and they could participate in that or not. And then we had a huge debriefing after it was all completed, and they could participate in that or not. So they could choose as much or as little of the participation as they wanted. So that was nice for having such a variety of students and getting it to fit into their schedules and their needs. So as far as the professional identity went, like I said, we tend to kind of be in silos, which is a shame because when we're out in practice, we're all interacting and working together. So it was nice to work with one another and see the different pieces and how everyone could be involved in handling the screenings and the referrals for treatment, amongst the different disciplines. And then another thing that we noticed with this was confidence. When students got to practice within their own discipline, they felt a little more confident, and then they came together with the other disciplines, and then they became more confident interacting in an interdisciplinary way. Another benefit of that was when they became confident with one another, they were able to do a little more networking with each other and then come up with ways to kind of spread the word about this new screening process throughout our community here in Anchorage. Next slide, please. So like anything new that you attempt in education, you will experience some barriers. And the biggest one that we experienced here was time. So as we moved through the interdisciplinary simulation and started incorporating this into our classrooms, it was time. So I speak mostly to nursing because that's the area where I teach. And in our nursing program, we have 3 basic programs. We have an associate degree program, which is 16 weeks in duration, with about 15 weeks devoted to classroom activities. This program has multiple clinical sites spread out throughout a very large state. Some of our students are, 800 to 1,000 miles away and have clinical sites out there. And because we have multiple clinical sites and multiple clinical times, we had to find a way to get this incorporated within the constraints of their student schedule. So there are, of course, barriers that keep you from having students come to class meetings and class assignments and class requirements outside of posted scheduled time. So that was a challenge as far as time goes as well, trying to get all of those done several times throughout the semester in the associate degree program. In the bachelor's program, we have a different issue with time. We have 7 weeks for our mental health courses, and 6 weeks of those are instructional time, with the final week being testing. So time became an even bigger factor when you had such a limited amount of hours to incorporate another bit of education that needed to be done. So we started looking toward our clinical placements to implement the teaching for students in that program. And then in our graduate program, time is also an issue, and we tried to incorporate the education into our clinical courses, and again, not enough space to incorporate everything that you would like students to learn. So we ended up changing that to our assessment course, our advanced assessment course. So those were some challenges at the time. The other barrier is facilities, so classroom facilities in particular I'm speaking about. So our classes tend to be probably smaller than a lot of folks experience with big lecture halls. We have seating for about 40 in our bigger rooms, and they are set up, you know, kind of like a lecture room. So not really conducive to interacting and role playing and practicing screenings and motivational interviewing. So just the classroom setup is an issue. The other issue is having enough classrooms to do several groups at one time. We just don't have the space, and like everyone else, other educational facilities in the country, we are trying to do more with the same amount of resources. So that became an issue for us. And then a third issue are the clinical facilities where we have nursing students, social work students, and psychology students. They are not, or they were not, quite ready to incorporate a new type of screening into their care at the facilities. So as we have moved forward and we have more new graduates in the areas, we have been able to increase that a little bit, but a lot of folks are reluctant and don't want our students using audit and DAST in their facility. They're kind of still stuck on cage screening. So that was a barrier for us too. So while we were able to give students education and practice in the classroom or within our simulation areas, actually getting them out into the community and being able to use it was a challenge. We are still contacting facilities out in the community and asking them if our students can come and do screenings there, and they're not interested. So that was another barrier, was knowledge in the community. We've done a great job, I think, here on campus with getting our students educated and doing some screenings with different student activities here on campus. But getting the information out into the community has been a slow process. For example, we started with our grant and doing our training here at the university in 2012, and it was just this year that our community mental health center incorporated some training for their staff there. So it's been slow. So that has been a barrier for us getting students educated and practicing in SBIRT. Next slide, please. So methods that facilitate. So now I'd like to expand on our interprofessional simulation a little bit. So the very first thing that we did here was the interprofessional simulation. Like I said, in our brand new shiny simulation lab, we started out by providing faculty training through SAMHSA, and we had grant money that paid for that, which was wonderful, and faculty were pretty excited to be getting involved in this. So we started with some faculty training. We then developed some scenarios to be used in this interprofessional simulation, and we recruited standardized patients. So we had a model that came in and pretended to be a patient, so everybody got the same opportunity to assess. We then brought in students, and like I said, we had the sessions where we would just kind of give them information about SBIRT, and then we offered sessions where they could learn to perform the screenings and the motivational interviewing and the referral for treatment, brief intervention. And then we had practice sessions for them, and then we actually had the simulation. So all of the variety of students participated in that. Faculty were there to kind of monitor what went on with that and to evaluate their scores on the audit and DAST tools. So something that was interesting with this is the provider students, so those that weren't in the justice department, tended to rank provide scores that put patients into a more severe category, whereas students in the Justice Department tended to be a little more accurate. So I thought that was pretty interesting. But we carried out the simulation, and then we held a debriefing, and students did feel much more confident and competent in performing the SBIRT screeners after we had that. The other thing that we did that helped facilitate getting SBIRT into the courses was just incorporating it into classroom learning, kind of like what Lydia talked about, you know, putting different pieces in at different times throughout the courses. So for example, when we talk about how to communicate with mental health clients, we would incorporate motivational interviewing into that and kind of use some of the SBIRT scenarios to practice that. So rather than having just one separate SBIRT session, we would kind of start incorporating those skills throughout our classes. We also began incorporating it into clinical experiences. So for the associate degree program, one of my colleagues has set up health fairs and screening fairs across the campus and is now still trying to get into community facilities and offer screenings for them. One thing that has been helpful in a state where alcohol is a huge problem and no one wants to really address it sometimes is to offer some other screening with it. So not just having the students go and do a health fair with SBIRT, but including some blood sugar checks or some blood pressure monitoring in there and kind of breaking in that way, and then the next time just going with the SBIRT screening. So we've incorporated it into clinical practices or experiences that way. For the associate, or for the bachelor's degree students, we have set up a separate day for them for their clinical experience. So we just take a day and we do another simulation, and then we do the SBIRT simulation for them. And like I said, the graduate students, we've incorporated that into their assessment course, and they have a separate day where they practice the SBIRT screeners and referrals. Another thing that we've done to kind of overcome some of the barriers with classrooms and getting out into the community or incorporating it and taking time away from some other lecture content is to offer online modules. So we have a great group of people here that oversee our grant that maintain a whole Blackboard site for us and have some videos on there, some screening tools, some scenarios, and some articles and things for students to look at. And faculty can take pieces of that and kind of make a customized online module for what's going to fit their program. So that has been very helpful. You can assign it as a homework assignment, students can complete it, and then when they come together in the classroom, they can do the role playing. So that's a way to kind of incorporate it as well. Next slide, please. So we wanted to take some time to kind of compare the projects. So Lydia was in a very urban area, and Alaska, the majority of our population is rural. Only about a third of it is here in Anchorage. So we wanted to talk about what it was like in an urban area versus rural areas, and then what it was kind of like in a densely populated area such as the Bronx versus Alaska, which has a really spread out population, and then nursing, the experience of nursing versus social work. So I'll go ahead and start us off with the rural aspect. So like I said, Alaska is it's the biggest state we have, but our population is only about 800,000, about 300,000, give or take a few thousand, is in the Anchorage Bowl area. So we're spread out quite a bit, and what that means. Sorry, I've lost my screen. So what that means is that we have lack of programs in our rural areas, sorry about that. I just lost my screen. Okay, I'm back. So we have not a lot of programs in our areas, not a lot of facilities that are able to even provide the screening. We have lots of communities and villages that don't have any healthcare practitioners or a hospital around. They rely on telemedicine folks coming in or folks flying in to treat them. So that was one challenge of implementing our project in our rural area. Lydia, did you want to speak to what it was like for you in the urban area?
Yeah, well, so we didn't have those challenges. We have people everywhere, a pretty high functioning public transportation system. One thing that I think you and I had talked about, that you had mentioned that I thought was really interesting and hadn't even occurred to me, is that our clients, or the students' clients, I should say, felt that when they were speaking to the students, it was pretty much, although they knew it was, going back to the student, and most likely hopefully they knew it would go back to the fieldwork instructor, but that there was a sense of anonymity. So if the student did a screening and intervention and found that they needed a referral to treatment, there wasn't any sense among the clients that they would need to, that other people might find out. They could go to treatment totally anonymously in relation to their communities and families. So that was one thing about being in an urban area, that it was, there's a lot of resources. The Bronx is considered under-resourced, but there's still hospitals. There's a lot of agencies that are trying to help. And there's this sort of anonymity that people want when they're dealing with a stigmatizing challenge, or talking even about a stigmatizing problem. And then maybe I'll just talk about the Bronx specifically, and then you could talk about Anchorage a little bit. Okay. Does that make sense, Cynthia? Yeah. Yep. So one thing about just going to the idea of stigma, so the Bronx has the highest rate of substance use in New York State. I think one of the highest in the nation, although with the current opioid crisis that we're losing that status, which I guess has its pros and cons. But you'll remember from when I was talking about my students, the Lehman College is actually a federally designated Hispanic serving institution, and a lot of the surrounding areas are predominantly Hispanic communities. There's also a lot of immigrants in the area. And so there were a lot of cultural considerations that were not sort of included in the SBIRT training material that we received from SAMHSA, and that we had to think about when we were having our students go and use this in the field. For example, like language was a big thing. Luckily, our students, a huge percentage of them are bilingual English and Spanish, but we translated all of the screenings and into Spanish. Ideally, we would have also translated our visual aid into Spanish so that it would have been bilingual there too. So that was a big concern. Also, talking about substances and with different immigrant groups can bring up can be even more stigmatizing for them. So one thing that we really tried to emphasize was normalizing the idea that we're going to screen everybody, but that meant that it was really important to us that at least our students were actually screening everybody. So the idea of universal screening was really important to try to decrease that stigma with everybody. I mean, I don't think there's any group that's sort of immune to stigma from substance use, but particularly with some of the immigrant groups, it was magnified. So the universalizing, normalizing, all of that stuff was important. And then being the other thing that we added, which wasn't part of the curriculum that SAMHSA gave us, it may not necessarily have had to do with the Bronx, but was just sort of like a statement about any consequences. So if the person was going to be referred out and wouldn't be part of that agency anymore, if they disclosed substance use, then we told them that. But anyway, so being multicultural and bilingual, those were some important things that we had to consider when we were looking at the SBIRT material in the Bronx. Cynthia?
Okay, yes, thank you, Lydia. Yes, so in Alaska, we have a huge state. We have the tallest mountain in North America, and we have one of the highest, we're one of the leaders also in the per capita alcohol consumption. Our alcohol mortality rate in the state is 3 times the national average, and about 2/3 of our Alaska Native deaths are related to alcohol. 30% of the adults in this state binge drink, so it's a huge problem here. It contributes to a lot of violent crime. We have the highest suicide rate in the country. It contributes to that. We have a lot of sexual abuse here and domestic violence. So as you all know, that the alcohol can greatly contribute to that. So some of our challenges here in Alaska in trying to change that is we have a transient population here. So people don't often think about that these folks come to Alaska, and the joke is that people come here and we call them sourdoughs because they get soured on the state. It's so cold and dark, and they don't have the dough to leave. But they are transient. We have people that work up in oil, kind of, in the northern part of the state, and they come and go for work there. We have a large military community here throughout the state as well. So that can be a challenge in helping folks with that transient population. Like I talked about, the sparse population in most areas of the state as well. And then there's a big culture here for drinking. Another kind of funny but not funny bumper sticker that you'll see around here is that we are a small drinking village with a fishing problem. Fishing is very big in Alaska. But there's kind of that culture that, you need to be able to hold your liquor, and for the women, you need to be able to drink with the guys. And so there's that culture to overcome there. But then we also have the Alaska Native population, who are the folks that are out in the rural communities mostly. There's certainly a variety, but there are a lot of Alaska Natives that are out in the rural areas, and they don't trust the non-Native people. So trying to overcome that and talk to them with our screening tools was quite a challenge. Motivational interviewing helped a lot with that, and coming at folks with the idea that this is not to label you as an alcoholic or to diagnose you as that or to call you a binge drinker, but to find out what we can do to help you with your health in general. So that was those were some of the challenges as far as being in our state here. So, and then as far as I talked about nursing, we have in our state, the majority of our students coming into nursing school are white students. We have a large number of Asian communities here, and of course a lot of Alaska Native communities. And so having those students go out and try to work with those other populations, it was difficult to overcome. And a lot of the organizations here in town where we would like to get SBIRT education implemented are run by Native corporations, and it's difficult to get in there because of that. There's still, even in 2016, a lot of mistrust there. Lydia, what were your experiences with social work?
I mean, I sort of talked about that it was important for us as social workers to be transparent about any consequences for talking about substance use, and to keep culturally related issues in mind. the other thing I think of when I think about social work doing this problem was sort of how it fit into that concept of professional identity. Of course, social work was the professional identity of everybody involved. But how does SBIRT fit into that professional identity? And so we tried to frame it that SBIRT is just a core competence. So in the code of ethics, competence is one of like the core values, and we tried to just frame that being able to screen, provide a brief intervention, and referral to treatment for substance use is a core competency. Every student should have it. Every student should graduate with it. And we had to convince our faculty, our students, and our fieldwork instructors that that was true. And I think we did a pretty good job of that. But that was an argument that we had to make. That was not what everybody thinks ever wants to do when they become a social worker. So that was a big part of it. Yeah, I would say I think that's enough about that for now.
Okay, thank you, Lydia. So we're going to run out of time here. I'm going to go ahead and ask. Would you please advance to the next slide? So I've touched on some of these sustainability issues. So now that we have had our projects at our respective schools and our respective coasts, some of the things that we found that help with sustainability are, including SBIRT-related course objectives into our courses, and including it as an assignment that students get a grade for. My experience is that if it's not worth any points, students oftentimes don't want to do it. Putting it in the course requirements and as part of their evaluation process in order to pass clinical, and offering the online options, in the hybrid where they do part online and then part in person. And I'd like to kind of open it up to you all for a couple of minutes to see what your ideas are, or maybe what kinds of experiences you've had in resolving some of these issues, these barriers. So if you would like to let us know what that is, please just go ahead and type into the chat box, and we'll take a look at what you have to say to offer.
Yeah, and while we're waiting for people to type in, feel free to type in while I'm talking. I'll tell you about what we did for sustainability. So we had this money for 3 years, but we had committed to SAMHSA that we would do something sustainable. And I had mentioned before that there was sort of like equivocation as to whether there was enough time or this took up too much time. So we ended up just finding an online SBIRT training module that we added to the practice courses as part, like all of the practice courses are hybrid. So we added it to the graduating year of the master's practice course as like part of the online component of the class. And then we did the same thing, and we made it going through the online module, an assignment for the graduating seniors who were in fieldwork placements in the bachelor's level. So that's sort of our effort at sustainability. So it seems a little bit like the faculty who thought that it took up too much time in the classroom won that one. Like we had done a lot of things to try to make it specific to our students in the Bronx, using addressing the bilingual nature of the clients and the multicultural nature, and dealing with sort of perceived barriers about who can and can't receive a screening for substance use. And so we have some concern that sort of a generic online module won't cover that as well, but that's what we're trying for now for our project sustainability. All right, I don't see any comments. Do you see comments, Cynthia?
I don't see any, and so I would ask if maybe we just can go to the next slide, and there's some references there, and just thank you all for joining us, and I'm going to turn things back over to Tracy now.
Thank you both. What a terrific presentation. What a rich discussion of the lessons learned and your experiences and ideas for others to take away. I know I'm looking forward to hearing this all over again on demand. So thank you very much. What wonderful programs to be able to highlight and to partner with CSWE to highlight these SAMHSA-supported programs. So let's take a couple of questions. I know we are getting close to our time, and so I want to thank everyone for joining us, and we may run over just a little bit. You are welcome to stay on. You're welcome to drop off if you need to get somewhere. You know this is going to be on demand. You can always come back and listen to some of the questions. But I want to focus, we have quite a few. I'm not going to take them all, but I want to focus on a couple of implementation questions. The questions pane is up in the right-hand corner, and those we don't get to, we may ask our presenters, or there are a couple of them we may be able to respond to after the fact. So if you have a burning question, go ahead and put it in there. A couple of questions on implementation in terms of, and I've heard this come up quite a bit, just being on the ground myself. For the interprofessional simulation, can you briefly describe a bit more about how students interacted interprofessionally? What did that look like?
Yeah, so this is Cindy. That is a great question. And what we did is we had folks in their roles doing the screening. So students from the Justice Center did screening with the client, and they would do that ordinarily, you know, as part of people coming into corrections. And we had nursing students doing it as part of an admission process, and social work students, the same thing. And then we would kind of hand off those kind of first line providers would kind of hand off to someone who would be doing the referral and doing maybe the more motivational interviewing piece, such as the psychology students, the PhD students, and the WAMI students. And then so they got to practice some interaction and handing off there.
All right, and Lydia, did you want to address that question as well, or take another question?
No, that's okay. I'll take.
Okay. Can you remind the audience of the settings where you were actually implementing the screening and brief intervention, just so that there are a couple of questions around just the settings where they're actually doing the SBI?
So in my project, it was social service agencies throughout the Bronx, New York, and surrounding areas. So they ranged from everything to senior centers, to high schools, to wherever you might find a social worker, with the idea that any time a person comes into contact with a social worker, there's an opportunity there to provide a screening, a brief intervention, and if needed, and then if needed, a referral to treatment. So it was really dozens and dozens of different social service agencies throughout the Bronx and surrounding areas.
Okay, that's helpful. Cynthia, in the settings that you were specifically implementing in?
So, of course, you know, we had the interprofessional simulation, but we have done a lot of screenings with students here on campus, either at the Student Health Services or in the Student Union, out in what we call the quad, kind of a open area, certainly not this time of year, but in the summertime. So those are mostly what we've done, where we've done the screening.
Okay, that's helpful. Thank you. And here's an interesting question, and this is what we often hear about: how do we make the create an opportunity for students to become champions when they are out in the field, and how they become champions of SBIRT. And so how do you know when a student trainee is ready to be a trainer, to go out in the field, be that champion, and to train others?
Well, that's a good question. Oh, I'm sorry. Do you want to answer this, Cynthia?
No, go ahead, Lydia. That's fine. Go ahead.
Well, in my program, that wasn't, we didn't really assess that. So we trained faculty to train the students, and we didn't have any measures to assess their readiness. And then we trained fieldwork instructors. In the introductory training, we just wanted them to have enough information about SBIRT to decide if their student could use it or not, and also to know what the student should or should not be doing if they were using it. So if they were doing if they got a process recording, they should know what to look for. And then in the advanced one, it was really to teach them how to use it more. But we didn't actually have any sort of measures for evaluating whether somebody was ready to train or not. And we really didn't address that with our students, although it would have been a great addition to our program.
Well, thank you, Lydia. Cynthia, did you want to add anything, or maybe I'll take one more question?
Yeah, let's take one more question.
Okay. Besides the screening steps, in terms of the brief intervention and the RT steps in the clinical settings, who was doing those? Were those done by the students? Was it a handoff? What was that model? What did that model look like for the BI and the RT?
We had our students doing it, the whole thing.
The students were doing it from start to finish, all the pieces.
In the social work programs. Cindy, what about your students or your nurses?
So in the nursing program, they are primarily involved in screening, the motivational interviewing piece as well for the brief intervention. But as far as the treatment goes, they did a handoff for that. They do a handoff for that. They do a referral.
Okay, terrific. And I'll take one last question here, and there are a couple of questions actually have come up about how the curriculum may or may not have been integrated with what we know about trauma and the ACE study and its relationship to substance use. You were talking about adapting your curriculum and integrating it to match the population that you're with, the students you're with, the context, that piece. And this is asking about how curriculum was integrated with what we know about trauma and adverse childhood events. Any thoughts about that?
So I have some thoughts.
I was just going to say, so we do integrate that. We do incorporate that into our curriculum in all of those disciplines that I mentioned. But as far as the SBIRT training goes, our focus has mostly been on teaching people how to carry out those steps and perform the screening and identify people that are at risk of health issues. We don't really ask any questions, related to past trauma when we're doing the SBIRT training.
Yeah, I'll just add to that. So the idea in SBIRT is that there's a universal screening. Everybody is being screened, and there's ideally being screened in ways that are sensitive and thoughtful, but basically the same way. The brief intervention is geared towards people with a mild to moderate substance use disorder that doesn't necessarily require referral to treatment. If somebody has a severe substance use disorder, then they would be referred to treatment, and it's in that treatment where things like trauma would be addressed, not in the screening or in the brief intervention, which is like 5 to 15 minutes of an intervention. So that's trauma stuff is not really coming up in that intervention.
Okay, thank you. Thank you. And in terms of, someone was asking about the articles that you've written. You mentioned one of those is coming out, not published yet. There was another article that I mentioned actually earlier when I was reading your bio, Lydia. And what we've done is posted the name of that article on the webpage for this webinar so that you can refer back to that. So it's listed in the bio for Dr. Ogden, and you'll be able to Google that in the Journal of Social Service Research. And Dr. Ogden and Dr. Montgomery, when your future articles come out, please let us know. We look forward to sharing those in our newsletters, and we could also post a link to the abstract under your webinar when they come out.
Great, great, yes, we will do that.
Yeah, thank you, that's great.
Yeah, absolutely. We want to be able to share with others and help people learn from what you're doing. And likewise, if there are folks joining this webinar that have they're publishing their own research on their own SAMHSA supported programs or other supported, not supported by SAMHSA, other organizations, internally funded, we always want to hear about it, and we welcome the opportunity to share your work with everyone in a newsletter. So just send us an email, let us know. Well, I'm going to stop here, and I'm going to thank Andrea Diaco, who started us off and is co-hosting this with us, and thanking Dr. Ogden and Dr. Montgomery for a terrific presentation today. And we have learned a great deal from you, and I think we're going to be continuing to learn more as your projects move into your sustainability phase and you analyze those results and share those with your colleagues. I want to go to just in the last few moments to let you know that all of the PowerPoints that were presented today are up on the website for this webinar. The on-demand recording will also be posted there. That's where you will also be able to request your certificate of completion. And there's an evaluation survey. It's really important. You may see this over in the pane if our technical facilitator is able to post that. And there it is. There's a link to the certificate of completion, and there is a link to our evaluation. And I can't stress enough the importance of the evaluation. It helps us to understand more about how you felt about the education we were able to offer you today. And it's really important to maintaining our funding and be able to provide you with the quality education you've come to expect in our series. And so if you could take just a minute to complete that brief evaluation survey. If you will watch this on demand in the future, and any of our on-demand attendees, we hope that you also, when you complete your review of the webinar, that you go to the on-demand recording evaluation link that is also posted on the webpage where you will access the on-demand recording and complete that evaluation afterward. We would be very grateful for that. The CE credit is 1.5 NADAC CEs, and you will get a certificate of completion after claiming and completing that certificate form. You will also receive a follow-up email with more information about how to access the on-demand webinar and some of the other information I just reviewed with you. So if you have any questions about this webinar or any webinar, you are welcome to contact me, and I have already given you my email address. I do hope that you will join us. This is the first of our series for the 2016/2017 series that you can see. There's some really exciting lineup already in the queue for you. We already have the ability to register for the November webinar, which is looking at opioid misuse and the impact on the workplace. But we're going to have, as you can see, as you get further along the schedule, there's a mini-series around the intersection of substance use and intimate partner violence. that will be taking place in January, February, March. And we're also going to be sharing more with you about promoting screening and brief intervention education in interprofessional settings over the course of the year. And so I hope that you will come back, register for these, and join us for future webinars. So thank you again. Please don't hesitate to contact me if you have questions about SBIRT training, technical assistance, implementation, evaluation. We're here to be a resource to you. And I will close it by thanking our partners, the Brief Intervention Group, the National SBIRT ATTC, supported by SAMHSA, and CSWE. And thank you again to our presenters, and thank you all for your time attending today. I appreciate that, and I hope you all have a great day. Thanks so much.